This talk is a little bit different, so I'm going to get into PANS rather than epilepsy, but we're actually going to, in this case, we're going to use an epilepsy tool in the treatment of PANS. Is the sound coming through okay, by the way? Everything good?
Yep.
Okay. So this is I'm going to do this as a case, but I think it's really an instructive case. So it's a boy who is now 17, but his symptoms first developed back in 2015 when he was 9. And it was a pretty explosive onset, but he had developed streptococcal pharyngitis. His ASO titers were high. Very soon after that, pretty severe onset of motor tics, very severe anxiety. He had trichotillomania. He was picking at his skin and his hair pretty repetitively. Also on his head, too. He had a little bald spot from picking repetitively. And then he had a very clear decline in handwriting. And that's actually a very useful tool for the clinician because it's something that you can actually look at the old handwriting and the new handwriting and see the difference very clearly. His mom was great because she also showed me video of him prior, and then I could compare that to what I was seeing presently. So, you know, as a clinician, when you see the patient for the first time, it's hard to tell their baseline functioning, but the handwriting is one great way to compare, and then also that video was another excellent way to compare, to kind of get a better sense of where his baseline had been. And so the other, let me just check the slides. I have little pop-ups here. I'm just going to shut those so they're covering me up. So initially he's treated with antibiotics with clindamycin, but that wasn't sufficient. So then in March of 2016, just to keep a sense of the timeline, we actually opted to try IVIG with him. He also underwent a tonsillectomy and adenoidectomy, and pretty soon after, so within a couple of months, he saw a massive turnaround. So he was, I would say, a dramatic improvement. Suddenly he's doing much better academically, his writing is clear again, he's focusing, he's participating in ski racing, so he's doing quite well both academically, socially, but then by March 2017, so let's just to give you that sense. So this is May 2016, doing very well. All the way really through 2016 into the next, almost a year later, suddenly he's very depressed again. He's restless. He's beginning to have a reemergence of the symptoms. The anxiety is much worse. He's given another course of IVIG. He'd only had one course, by the way, when he had the tonsillectomy and adenoidectomy. It was just one course at that time. But he's given a second course, he's given solumedrol, but at that point, still not doing great, and we're seeing not just the anxiety worsening and the tics worsening, but also intellectually, he's not able to do some pretty basic tasks that were not an issue for him prior. He can no longer count change, for example. He's beginning to, part of his OCD is he was very focused on NFL quarterbacks, and he would watch the same clips over and over repeatedly. And that was almost the only topic that you can engage him in conversation on. So he really couldn't have a meaningful conversation. It was just this repetitive need to watch the same YouTube videos again and again. So he had quite an evaluation. He undergoes whole exome sequencing, has an MRI, everything's normal. But one thing of note is his neuropsychological testing really shows someone who's doing extremely poorly on cognitive measures. So if you hadn't known his prior functioning, you would think that this is a child. At that point, he really looks like a child who has severe intellectual disability. You could even say he looks like he has autism spectrum disorder because he's not engaging socially, very little meaningful conversation. And he underwent quite a few medication trials, by the way, through this time without success. So he underwent a host of medications that were in the psychiatric or neurological realm. He underwent antibiotic courses. He also had immunomodulatory therapy. He eventually progressed towards rituximab, so he had gotten rituximab and IVIG, but still remained refractory. So, and I mentioned this is a neuromonitoring case, but just to first step back, so I'll get to the neuromonitoring part, because that's actually what is really unique about this particular patient. But just to step back for a second, he was, one of the mainstays of his therapy was IVIG. He had an initial response, but he had lost that. And rituximab, even that, did not seem to turn around his symptoms. So it's worth noting that the evidence for the IVIG piece, it's just worth, I'm going to just step back for a second and talk about that. because there's really, to date, there's really, I would say, one good prospective trial in IVIG, and that was done in 1999. And it hasn't, as part of Susuito's group, and it hasn't really been replicated in a larger series since. And I think that's interesting, because it's, you know, a lot of time has passed since then. But that was probably the single best trial, and it did show efficacy. It was 30 patients who originally enrolled, but 29 who completed it. And the tic symptoms had improved significantly, not just with IVIG, but with plasma exchange as well. It was looking at both IVIG and plasma exchange. Plasma exchange generally has higher risk, so IVIG is often preferred in children. And so both the tics and the neuropsychiatric symptoms had improved using that. There was an attempt to repeat that, but this study that was done in 2004, the average age of the patients was 28. So it's a very different population. And so there was no difference there in tic severity, although the OCD symptoms were somewhat improved. But I would argue that these are not really comparable trials because of the age difference. And then more recently, there was a retrospective review for PANDAS patients and IVIG showing that there was really a good benefit seen in each of the patients, but you had a couple that needed to repeat the course, and there had been recurrence of symptoms. So repetition of courses seemed to be an important aspect of that trial. But again, this is retrospective, very small group. So we're talking about a treatment that still, to date, the best study is more than 2 decades old. And so we're still in an area that, with IVIG, where most insurances will not accept it as a treatment. Some states have legislation for PANDAS that requires medical coverage now. Massachusetts is one of those states, and I believe Illinois is another. And so that does help the clinician to get approval when needed, but it's still a very difficult thing in most parts of the country to get approval for. So the IVIG part we were struggling with, and I showed you the list of meds. He was really not showing progress at all. So to step back for a second, I had a patient some years earlier. It was actually the first patient, I think, with autism who'd ever received deep brain stimulation. So it was a patient of mine who was essentially locked in from her OCD symptoms. She wasn't leaving the house. She wasn't functioning in any capacity. This is from a magazine article about her, but we did write it up as well. And so she had received a deep brain stimulator with pretty dramatic change and improvement in her symptoms. She was suddenly able, not that it cured her symptoms, she remained delayed, but she suddenly was from being completely locked in, where she would just repetitively wash her hands in the sink, couldn't leave the house, would not engage at all socially. She was able to participate in a bowling league, participate in Special Olympics, have conversation with me in the office visit, was much more talkative and interactive. And the other part too is she was doing really a lot of kind of self-injurious type behaviors with her hands, causing a lot of callus formation. And that too had improved pretty significantly after use of a deep brain stimulator. So that gets into a different topic. So this is not something that's used in autism at all. Apart from my one case, there was a case in Germany, but that was very different. The case in Germany was for severe self-injury and aggression. And that deep brain stimulator was placed in the amygdala, whereas my patient was a thalamic DBS. But DBS is not approved for Tourette syndrome either. However, there are growing data suggesting that it can be a useful treatment in Tourette's, as well as OCD. And so just to give you a sense of some of that, it's mostly, at this point, it's mostly case series, and showing that there's some partial efficacy for medication-resistant Tourette syndrome. But there's still no consensus on what the actual target is in the brain. So that creates a challenge. We don't really know which target or targets work best. In terms of when to consider it, the red and orange lines are examples of the Tourette's scales on the y-axis, but in cases where you see patients where they're having just a severe worsening of the Tourette symptoms and just no improvement, those are really, and resistant to medication, those are the situations where one might consider this therapy. And again, it's still not FDA approved, but it's something that may be considered in those medically refractory cases that are not showing any remission. Whereas the green line really shows what's more typical, which is that we do more typically see an overall improvement as we progress towards adulthood. That's why 18 is the dashed line. Most patients will get better as they enter adulthood. Their prefrontal cortex is developing. They're better able to suppress the tics. But for those who don't, I think DBS is a consideration, but we still don't know what the right targets are. And there have been really 3 main targets that have been proposed. So the anterior limb of the internal capsule is sometimes done. You could do centromedian complex or the globus pallidus interna. The patient that I had with autism was, we used centromedian complex was the target for that patient. And again, with good improvement. There's also been some suggestion in literature that if you have a patient with both Tourette's and OCD, you might actually need to go after 2 different targets. So you might have to consider, you're usually doing DBS with 1 lead on each side, going to a single target. But in the case of this combined Tourette and OCD, you might have to consider actually 4 leads, 2 different targets on each side. And so that dual target strategy, I mean, this was just a report of 2 patients. These things these therapies are not widely used, but suggesting some overall beneficial outcome when you approach those combined patients in that manner. And then there's this so deep brain stimulators are not monitoring and stimulating based on what it's interpreting. But there's this other approach called responsive nerve stimulation, where you actually have a computer that's interpreting the signal and stimulating based on the signal it's reading. And that's used primarily for epilepsy now. But even in tics, there's this one study indicating that responsive nerve stimulation actually works better than a deep brain stimulator paradigm. And so this is really showing the reduction in these tic scales, but the blue is a responsive nerve stimulator versus the orange using just a paradigm of a deep brain stimulator that fires automatically at a preset interval. So if you actually are doing responsive stimulation, the computer is interpreting the brain signal, and based on that brain signal is selecting when to fire. And keep in mind, these are cyclic conditions, so they change. The brain signal and the symptoms are changing. They're fluctuating all the time. So the responsive nerve stimulator is really firing when it needs to. And this is what a responsive nerve stimulator looks like if you hold it. It's a little titanium shell, and this shell basically replaces part of the skull. And then you can see towards the base of the palm, there's a lead with 4 electrodes. That would sit on that particular lead is made to sit on the surface of the brain. That's for cortical stimulation for epilepsy. But you can actually replace that too with just a thin wire that would be used to go into a deeper site. And this is sort of a graphic of what that would look like. So you can see that you would have this little computer is implanted in the skull, replaces part of the skull, and that is the entirety of the computer. Most of that is actually battery. And then it's a closed loop system. It will interpret the brain signal, make a decision as to whether it requires stimulation, and then stimulate. And you can adjust those settings over time. So you can get better and better at how it's adjusting its paradigm. This is not the patient I'm presenting, a different patient of mine who's receiving this. So this is from an actual patient of mine, and that's what the surgery looks like once it's implanted. So what you're looking at there is around the corners. So this is the skull, and that's the computer right there. And it's screwed into the skull, and you can kind of see out of the corner the wires are buried. The wires are kind of going into the brain right there. The first part is actually to put the wires into the brain, into the target, and then you bring those to the surface, and you put the little computer on, attach them, put the skin back over, and it just sort of heals in place. So think about like if you've had a hip replacement with a titanium hip or something, same idea. The skull is going to form scar tissue around that, and it should be as strong as it ever was. So that's a responsive nerve stimulator. And you can kind of guess I wasn't really just talking about that for the sake of talking about it, but this patient actually did receive one of those. It's the only patient I know of that I know of with PANDAS who's ever received this device. So he underwent this in 2020. The device is NeuroPace, and began the programming session in 2021. Initially, with the programming, he actually got a little worse. He got angry. His OCD actually seemed to increase. We had to actually adjust the settings downward. And we opted to restart IVIG. I mean, he had this new device in place. I thought we would restart that. That's in April 2022, and I'll show you this on a graph. And he continued to receive monthly courses since. So now he has 2 treatments effectively. He's got a responsive nerve stimulator placed in a thalamic target, and he's receiving IVIG. Now here's where this thing gets kind of interesting this is the outcome, but I'll get to the graph after this. But what happened subsequent to the IVIG is he had pretty much a full-on remission. I mean, he had a dramatic improvement. He used to have coprolalia, which really limited his ability to do anything. He couldn't go to restaurants. He had not been to a movie in years. He really had no friends. He was kind of locked into the house because he couldn't control the curse words that would come out. He couldn't engage in conversation before. He was completely locked in by this need to watch these YouTube videos over and over. Now the vocalization stopped, the cursing stopped. He's happy, he's social. He's now playing pickup basketball at the YMCA, meeting new friends. He's participating in cross country. He can go to restaurants. He went to the movies for the first time. Pretty dramatic improvement. And this is what I think is the interesting part of all this, is that this device records, so it's stimulating, it's also recording. So we now have a little window into what's happening in the brain. And what it's doing, so I won't get into the specifics of what it's identifying as an episode, but it's sort of programmed to look at brain activity that it interprets as being abnormal. And it's a little hard to see the dates, but this is February 2022. Whoops, I jumped one ahead. So in February 2022, this is when he had the device placed. He was still a little angry, and this is where he gets IVIG for the first time. And just get a sense of this map. So here he's not doing well, and here he's doing well. And you get that immediate sense that what it's picking up, what the computer's picking up as abnormal episodes, has generally moved towards declining. So, again, he's doing poorly here. His IVIG is given here. And overall, there's this decline in those abnormal, in what, again, the computer's interpreting as abnormal. If you zoom in on this a little bit, you can almost get a sense that when the IVIG is given, he's usually having a little bit of a peak. And then after you give it, it just seems like there's a general decline in terms of the activity. It's not perfect, but you can kind of get a sense that it gives you a sense that the IVIG is very possibly having a direct effect on his brain activity. And again, we're monitoring here in the thalamus. So there may be other targets that would be useful. But this is really a situation where we have a possible benefit from a responsive nerve stimulator too, which is really interesting. That's never really been used in PANS pandas before. It's very rare that this kind of responsive nerve stimulator has ever been used in Tourette's or OCD. And it really demonstrates, this is the first example of physiologic monitoring with IVIG in PANS pandas as well. So this gives you a little bit of insight into what's happening physiologically, at least in the thalamus, with IVIG infusion. Again, if you think back, the prior studies, there's very poor clinical trials. Just that one Susuito study with 30 patients was really the best we had 20 years ago, but none of those used physiologic outcomes. They're really looking at patient outcomes based on their tic rating scale and their OCD symptoms. But this is really the first example of something that's monitoring brain activity with treatment. And this is him today. This is how he's doing. He's participating in cross country and going from, this is a kid who couldn't leave the house, who was watching the same YouTube video again and again, and would, going from that to participating in cross country, coming into my office, having amazing interactions. Yeah, so it is, the visits are tearful now, but they were tearful before too, but they're tearful now, but happy tearful. So it's an amazing, uplifting outcome that we had. So I just wanted to share that because it's an unusual case, it's an unusual treatment, and it was not something that I would necessarily advocate for in every patient by any means, but it does suggest that there may be something more we could do as far as neuromodulation.
Thank you, Dr. Gaitanis. We have Dr. Fry coming up next.